It's very common during entrainment mapping to entrain the proximal coronary sinus electrode. So here we have the coronary sinus catheter wrapping around, and I've just put an outline or a shadow of the left atrium here. This doesn't exactly match the anatomy of this fluoro image, but it gives you a rough indication that in this view, which is an LAO view, you can see that your tricuspid annular catheter or your halo catheter wraps around the right atrium like this, with the lateral wall of the right atrium here, or the heart border. And then the left atrium would kind of sit behind and to the left of the right atrium. So the right atrium would kind of sit like, let me say, the right atrium would sit something like this, and okay, something like that. It's a bit of a poor drawing, but for example, so that's the tricuspid annulus, and that's the right atrium. So the right atrium will sit something like that. And so we've got the coronary sinus catheter, and it's very common during atrial flutter entrainment mapping to map or entrain from the coronary sinus. And if the coronary sinus proximal electrodes are within 30 milliseconds of the circuit, then it's probably a right atrial flutter. And then if you entrain from CS1-2 or the distal coronary sinus electrodes, then and the post-pacing interval is within 30 milliseconds, then the flutter circuit is probably within the left atrium rather than the right atrium. However, mitral isthmus flutter is actually just mitral annular flutter. So it encompasses the septal aspect of the mitral annulus. So let me remove some of this clutter. So this white circle here, the faded white circle, is the mitral annulus. And mitral annular flutter is a flutter circuit that just rotates around the mitral annulus. So it includes a septal portion and the posterior septal portion of the left atrium right next to your proximal coronary sinus electrodes, and it includes the lateral aspect of the left atrium right next to your distal coronary sinus electrodes. So when you perform entrainment mapping from the proximal coronary sinus, it's incredibly close to a mitral annular circuit. You know, we're used to talking about tricuspid annular circuits or CTI flutters, but mitral flutters are also close to the proximal coronary sinus electrodes. And if you perform your entrainment mapping from the distal coronary sinus electrodes, that is also very close to the mitral annular circuit. And if you perform entrainment from your mid-coronary sinus electrodes, that's also very close to your mitral isthmus dependent flutter circuit. And so coronary sinus entrainment often yields fairly short post-pacing intervals regardless of where you entrain from for mitral annular flutters. So they can, if you only perform entrainment mapping from CS9-10, then you might say, oh, this is right-sided. But if you then perform entrainment mapping from CS1-2, that will also be located within the circuit, indicating that this is not right-sided, but more likely to be mitral annular flutter. So just keep in mind that mitral isthmus-dependent flutters can have short post-pacing intervals regardless of which pole you pace from or entrain from the coronary sinus, because the coronary sinus is located on the mitral annulus. So mitral annular flutter will be close to your coronary sinus catheter. The disadvantages of activation mapping for atypical flutter is that it generally requires a multi-electrode mapping catheter, which might have a larger sheath size, and it may also be more expensive. But it's really required to have a high density map. You can do a low density point-by-point map with a linear catheter, such as an ablation catheter, for example. But generally speaking, for the highest resolution map, a multi-electrode mapping catheter is really going to be much faster and give you superior resolution and superior understanding of how the flutter circuit is propagating. During activation mapping, there is also a small risk of creating ectopy. And so when you bang one of these splines or one of these splines or one of these splines against the left atrial or right atrial wall, you can create an ectopic mechanically. And that ectopic could also terminate tachycardia, although it seems to be less likely to terminate tachycardia than entrainment mapping, but that is a risk. So with all those caveats out of the way, let's talk about mitral isthmus dependent flutter. Well, as I mentioned earlier, mitral isthmus-dependent flutter is a circuit, or flutter circuit, that rotates around the mitral annulus. So we expect our coronary sinus to be here, and therefore our coronary sinus catheter to be here. And these in red would be the proximal electrodes, and these in red here would be the distal electrodes. And so you can see that this circuit is rotating around like this, and so it's in close proximity to the coronary sinus catheter. So no matter where you entrain from, you're often close to the circuit. So mitral isthmus-dependent flutter is simply atrial flutter rotating around the mitral annulus in the same way that cavo-tricuspid isthmus flutter is flutter that rotates around the tricuspid annulus rather than the mitral annulus. So that right atrium would be something like this. Let me do this in white, perhaps. Right atrium would be something like this. Okay, and then you'd have your, like this, and then this is your cavo-tricuspid isthmus. CTI flutter rotates like this. And so mitral isthmus flutter is kind of the mirror image of that, but on the mitral annulus. It can rotate in a clockwise or anti-clockwise fashion. So what is the mitral isthmus, and what is the mitral isthmus anatomy? Well, generally speaking, when people say the mitral isthmus, they're referring to what we call posterolateral mitral isthmus line. So posterolateral mitral isthmus line is the region between the mitral annulus. So you've got the mitral annulus that kind of, let me just do this like this. Mitral annulus sits like this, so this is fibrous tissue. And then here you've got the left inferior pulmonary vein. And so generally speaking, when we say posterolateral mitral isthmus line, we mean the region between the mitral isthmus and the left inferior pulmonary vein. So it's this kind of red line here. This is the most common anatomical location to perform a mitral isthmus-dependent flutter ablation because it tends to be the shortest line. There are other lines, and I'm going to touch on those in a moment, but this tends to be the shortest line and by far the most common ablation line for mitral isthmus-dependent flutter. And the idea here is to burn between two electrically inert boundaries, just like any other atrial flutter ablation. So during CTI flutter ablation, we burn, so if we have a right atrium in an RAO view here we have the tricuspid annulus, and then we have the IVC here. So during a cavo-tricuspid isthmus ablation, we burn between the tricuspid annulus and the IVC. So they're two electrically inert boundaries, the fibrous tricuspid annulus and the venous tissue, which doesn't conduct of the IVC. So the same concept applies here. We're burning between the fibrous tissue of the mitral annulus and the venous electrically inert tissue of the left inferior pulmonary vein. Some physicians also like to ensure that the pulmonary vein is electrically inert by performing a pulmonary vein isolation, but we'll get into that in a later slide. The other two mitral isthmi, or the two alternative ablation lines for mitral isthmus-dependent flutter, or mitral annular flutter, is an anterolateral line, and an anterolateral line connects the mitral annulus to the venous tissue of the left superior pulmonary vein, and it's on the anterior lateral surface. So this is lateral, this is septal, and this is the anterior, and behind which we can't see the posterior wall. So this is an anterior lateral line, and that's this one here. And then there's an anteromedial line, which is an ablation line performed on the anterior wall, but it connects it a little bit more medially to the right superior pulmonary vein. So this is the right superior pulmonary vein here. So again, we're either way, we're anchoring our ablation lines from the electrically inert structure of the mitral annulus to an electrically inert boundary, usually venous tissue of some pulmonary vein. These are less commonly employed because you can see that they're longer than the posterolateral line. So the posterolateral line tends to be a shorter ablation line, so that tends to be attempted first. The problem of the posterolateral mitral isthmus line, so just to orientate you, this is our anatomy here. So we've got pretty much an LPO view, so left posterior oblique. So Here, this is the posterior wall of the left atrium. This is the left inferior pulmonary vein, left superior pulmonary vein, left atrial appendage region here. The mitral annulus is here. And then here, this is the posterolateral mitral isthmus line. And the tissue here can be quite thick, although it's often not as thick as an anterolateral line, which is also a longer ablation line, but nevertheless, the tissue here is often quite thick. So it's hard to achieve transmurality when ablating from the endocardium. So epicardial ablation across the endocardial ablation line can often still occur because of muscle bundles from the coronary sinus and ligament of Marshall. So you might perform an ablation from the endocardium here, but you can see here that there's all these kind of muscle bundles, including this structure here, which is the ligament of Marshall structure, which cross epicardially the posterolateral mitral isthmus region. So we might burn the endocardium, creating endocardial scar, but there may still be epicardial conduction via muscle bundles arising from the coronary sinus and ligament of Marshall. And so it's often difficult to achieve endo and epicardial block from simply ablating the endocardium. This is just a nice anatomical kind of example of the anatomy of the mitral isthmus. We've got the right atrium in grey, and here we've got a posterolateral mitral isthmus ablation line here. All these red dots represent places that we've ablated. And you can see the physician is anchoring it to an isolated pulmonary vein to the mitral isthmus. So this is a pretty standard posterolateral mitral isthmus ablation line. But what you can see is the coronary sinus wrapping around and across the mitral isthmus. So you can imagine that burning the endocardium of the left atrium might not affect muscle fibers that run on the outside of the coronary sinus, for example. And so that can result in conduction when you pace, for example, coronary sinus 910. That can result in conduction crossing this line still, and you not able to achieve endocardial and epicardial block. And of course, the goal of a mitral isthmus ablation line or any flutter ablation line is to achieve block. And if you can't achieve block, then that can actually lead to proarrhythmia. So this is a nice visual illustration of how the coronary sinus wraps across the posterolateral mitral isthmus and how that can contribute to making it difficult to achieve block, because you might have muscle fibers from the coronary sinus that extend to the endocardium here, and so you might have conduction that travels across the mitral isthmus epicardially and then it exits endocardially here, and so then it depolarizes the endocardium from this location. So there's an endo-epicardial connection here. We use differential pacing techniques in order to demonstrate posterolateral mitral isthmus block, in the same way that we use differential pacing to demonstrate CTI block during CTI ablations. So let's say we pace from the coronary sinus catheter here, and that pacing stimulus cannot travel across a blocked mitral isthmus line. We have an ablation catheter located here, and so our pacing stimulus to reach that ablation catheter has to travel in this direction, like this. And so that will take quite a bit of time. So it'll be quite a bit of time until we develop an EGM on our ablation catheter. And if you measure that time from the CS to the ablation catheter, you get 150 millisecond transismus time. If you then move that catheter further away from the line, so it's anatomically more distant from the coronary sinus catheter, it will actually be electrically closer to our pacing site, even though anatomically it's further away. And so that results in a shorter transismus time, indicating that block or conduction is not occurring across this line and that block is present. If this number increased when we moved it further from the line, so if it went like that, that would indicate that conduction was occurring slowly through the mitral isthmus. But since it gets shorter, it indicates that the mitral isthmus is blocked. Generally speaking, transismus time across the mitral isthmus should be more than 138 milliseconds. And that has a specificity of 63% and a sensitivity of 87%. So generally speaking, you're looking for mitral isthmus transismus times of around 130 to 140 milliseconds at least.